Yeah, good afternoon, Councillor.
Sorry. Hello, Anna.
Hello, yeah, I've started recording it, so it should be live now.
Okay, thank you very much. Okay, good afternoon and welcome to the Health, Wellbeing and Social Care Portfolio Decision Meeting, first virtual meeting of the portfolio. I'm Councillor Matthew Winnington, the Cabinet Member for Health, Wellbeing and Social Care, and I'm chairing the meeting today. We are meeting virtually in response to the limitations placed on governance by the COVID-19 pandemic. Until recently, the law stated that all members had to be present in the room to make formal decisions at meetings. However, the law was amended in response to the COVID-19 emergency, and councils are able to hold public meetings virtually. This will be in accordance with the local authorities' coronavirus flexibility of local authority meetings regulation 2020 number 392, the regulations. Members of the public were invited to view this meeting, and there's been the opportunity for written representations to be submitted. This is a new experience for many participants, and we will all need to exercise patience and understanding while we familiarise ourselves with the new arrangements. Those present are requested to keep their microphones on mute and to only turn them on when they are called to speak. Members are requested to keep their cameras turned on at all times. Officers are requested to turn their cameras on only when they are presenting their reports or answering questions. If anyone would like to speak, please write their name and RTS request to speak in the chat function. That doesn't include officers who I will introduce to bring in to introduce their reports, or where they've been asked specific questions by members. Please access chat from the horizontal menu bar, right click to bring it up, not the icon on the left hand side. Please kind of ask everyone taking part today to confirm that they are present. So I'll go through members first. So Councillor Graham Heaney. Oh, we seem to have lost Graham. Okay, Councillor Jeanette Smith.
Present, Chair.
Thank you. As I say, I think we did have Graham Heaney there a minute ago, but he seems to have disappeared. So hopefully he'll be back with us in a minute. And then I'll just go through the officers present. So Helen Atkinson.
Present.
Andy Biddle.
Present.
Alan Noble.
Present.
Helen Simmons.
Present.
Richard Webb.
Present.
And Anna Martin. Well, I think we might have lost Anna as well. Okay, Graham.
Hi, it's
Graham's
completely,
back.
yeah, it completely froze out. Couldn't do anything, couldn't change anything. So I managed to get out and come back in again. So I don't know what's going on.
No problem. As I say, I think we've lost Anna as well. So.
Oh right, okay, you are.
So you're not the only one, but
good.
I'll just pause for a moment. If we just all mute for the moment, just to give Anna a chance to get back in, as Anna is our local democracy officer and takes the minutes. So we'll pause for a minute or so just to see if she can get back in. And here she is. Hello, Anna. Oh, you're on mute.
Yeah, so I dropped out for a couple of minutes and this sort of thing happens. Whereabouts have you got up to?
We've just done everyone present, so you're the last person I was just going to ask. But
Right.
you're present, but you are. So we haven't
Present.
started.
Yeah, right, present.
Yes, thank you
Anna
very much,
Martin's
Hannah.
Democratic Services.
That's great. Okay, thank you very much. Anna, do we have any apologies for absence?
Angela Dreyer, who is represented by Andy Biddle.
Okay, thank you very much. Okay, members, Jeanette and Graham, do you have any declarations of interest?
Yes, I have one, which is item 5, update on residential and ethical care charters. I'm in paid employment of Hampshire branch Unison, so I can't take part in that discussion.
Thank you very much, Jeanette. Graham, any declarations?
No declarations of interest, no.
Okay, thank you. And I have none either. Okay, so next item on the agenda is item 3, the section 58 decision taken on the 26th of March, allocation of nutrient neutrality credits for Longdean Lodge and Edinburgh House. This was taken under Chief Executive Section 58 delegated responsibility. We don't have to make a decision on that now, we just have to note it. That was regarded as a key decision. So and this was before we had the opportunity to do meetings virtually. So that was a decision that was taken after discussion with myself and members from other parties. The Chief Executive made that decision, so that's just for noting. So regard that as noted. Item number 4, so the Wellbeing Service annual performance update. So we will have the updates from Helen and Alan, and then Alan will just give verbal updates and developments since the report was written in March, because this would have come to our March meeting originally. So over to you, Helen and Alan.
Okay, so Helen will do most of the presenting of the report and the detail, but we've just brought the report to summarise some of the progress and the improvements that the service has made under Helen's leadership over the last year or so. Also to highlight some of the innovation work that Helen's undertaken and the team are developing around long-term condition hubs, for example. And then at the end, Helen will cover some of how we've adapted the service under the COVID-19 to continue delivering in a different way. So I'll just hand over to Helen, who's done an excellent job leading the team and can highlight the improvements that have been made.
Thank you. Would you like me to share the report, or are you happy for me to talk you through it?
I'm happy for you just to talk through it, Helen.
Okay, thank you. This report takes us up to towards the end of last year, and just highlighting the key information. The referrals in the Wellbeing Service following the restructure in Vanguard remained fairly static, just over 3,000 per year, predominantly coming from primary care and self-referrals. Demographics have remained static for the last 4 years, and about 2/3 of our clients are male. We did some investigating work because about 2/3 of the clients didn't come into the service following referrals, so we've made some headway in improving this. Of the 3,000 odd referrals that we had, 2,028 individuals took up support with us, and we provided 1,654 interventions, predominantly around smoking, which we provided support to 1,094 people. We also screened for alcohol and were very successful in detecting and offering brief advice to those showing increasing or high risk of harmful drinking levels. We also provided 49 onward referrals and undertook 30 joint working with other services and just over 1,000 signposts to other relevant services to support people improve their health. Our smoking cessation outcomes were fairly in line with the national average. Of the 1,094 that set a quit date, 523 successfully quit at 4 weeks, and we followed this up with a 12-week outcome of the 1,094 setting a quit date. Around 29% of people had remained smoking. Stop smoking, sorry. We provided 475 weight management interventions with a service level average of about a 2 kilo drop, but within that there was a range, some people losing significantly more than 2 kilos. We also provide training and trained 481 healthcare professionals working within the city in a range of courses, including smoking cessation, brief advice, the Connect 5 mental health training. And we devised bespoke courses for certain services such as midwifery and health visiting to support them having difficult conversations around BMIs and smoking and substance misuse. We also got involved in the long-term condition hub pilot, which didn't actually officially start till December and obviously now has ceased under the current pandemic. This was a fantastic project for us to be integrated into an individual's care package, so that those with long-term conditions could get the best access to healthcare or health improvements from the beginning. Overall performance within the team has significantly improved in the last couple of years, and we are currently maintaining those levels. And that's it really. And just to update you, since March, when everything stopped, we have managed to continue a good level of support. We've got about 245 active clients who we are supporting with either telephone support or Zoom meetings, and it's going very well, considering that we're not able to provide a face-to-face service at the moment. Would you like me to touch on the work that we've been doing with the homeless?
Helen, yes, that would be really helpful.
So we had a fantastic opportunity with the homeless being sited in the Ibis hotels to set up a wellbeing clinic in there, predominantly to support the prevention of smoking within the hotels. We've had 72 people sign up. We've got 14 people who've stopped smoking altogether, and some fantastic outcomes with people reporting feeling safer in their rooms, that they're not having to go outside to smoke. They've never tried vaping before, and they're seeing improvements in their respiratory health and adapting quite well to the vape. So it's an ongoing thing. So as at the 1st of July, we had 72 people signed in with us. I would suspect that they were more, because we've moved into Ibis 2 now, and 2 weeks ago we moved into Hope House, and within the next couple of years we're hoping to set up wellbeing sessions within Foster Road and U House to support those in supported housing. And that's about it. Thank you.
Helen, you said years. I presume you mean weeks in terms of Foster Road.
Apologies. Yes, we're hoping next week.
That's brilliant. That's great to hear. Thank you very much. Alan, was there anything you wanted to add to Helen's report?
No, just that Helen's overseen a period of transformation of the service. Although Helen said that the referrals had stayed constant over the period that the service has been running, what she hadn't mentioned is that she's got about half the staff, in fact probably less than there was at the original outset of the service. So she's maintained the referral levels with half the staff. So I just wanted to say thank you for Helen for the work that she's done around that.
Thank you very much. Right, Jeanette, you wanted to come in on this?
Yes, just on that sort of final point from Alan. It's half the service it was, and there's predicted to be a very big spike in wellbeing, alcohol, and probably smoking. So how resilient is the service, and how sustainable is the service?
At the moment, we are achieving a lot of efficiencies with practitioners working at home they're able to do more because they're not having the travel time. So in the short term, we don't think our capacity will be impacted by, if we do get an increase in referrals. The longer term, I couldn't say. It's hard to tell at this point, because at some point we hope to be back to face-to-face work. It appears that weight management clients in particular want to have face-to-face sessions because they want to be weighed. So whereas the smoking clients seem far happier to be supported by Zoom or telephone. At the moment we have the capacity. In the medium to long term, I would think we might need to look at what we're doing.
Okay, thank you.
Did you want to say any more, Alan?
I was just going to echo that. What the current period has taught us is that we can deliver differently, and that the use of telephone and online support does. We could potentially have 3 appointments in the time that we would normally have 1 because of travel time. So that it does. We've been presented with an opportunity now to be able to meet any increased demand, but to some extent there is a great unknown, and the alcohol aspect might be a great unknown. We just don't know whether people's drinking will drop down once they go back to kind of more sense of normality, and they're not at home every day drinking from the afternoon onwards. So we don't know the demand that will be upon us.
Thanks, Alan. Graham, did you have any questions or comments on this one?
No questions. I mean, I have to say, I think Alan must be congratulated for the work they put in to keep things going over the COVID period, but also for the work they've done, make it more efficient. It's always an issue about how you make things more efficient. I'm sure we've learned something from the current crisis about how we can do more remote contacting, which will obviously be something we can take forward in the future. So I think congratulations to them both for the work they've put in.
Thank you.
Excuse me. Yeah, I'd just like to echo the thanks that's been given, and I know what a great job the team are doing. I've been fortunate enough to meet a few of them, both in a professional capacity when I was working as a sport worker with one of my clients, but also having met them in a more we did some television either earlier in the year, end of last year as well, with one of our success stories, and who I think is going to be cropping up in flagship again, which is really good to see, because I think actually blowing our trumpet about this, and the fact that it's a free service available to people in the city is fantastic. And in the additional bit, the work that's been done in the hotels with people smoking has been absolutely outstanding, and to get that number of people involved and have 14 people who've given up altogether, having worked with homeless people, and how prevalent smoking is within that community, and why smoking, for many obvious reasons why smoking is so prevalent. That's a real tribute to the hard work that's being done. So I really like to thank the Wellbeing Service for all their work over the last year up to the end of that report, and also of course during COVID-19. And people have mentioned, it is really important that we, like with everything else, we make sure that the planning for recovery of all our services takes into account as much as we can what we project is going to happen, but also it really lends things to the fact that we need proper financial support from the government to make sure that we can continue doing these services, because they have such a positive impact on our communities. So thank you very much. Thank you very much, Helen and
Thank
Alan.
you.
And Helen, I will let you get back to your holiday now.
Thank you very much.
So thank you very much for your time, and Alan as well.
Thank you. Bye-bye.
Thank you. Okay, so we now move on to I have now got the opportunity to say that I approve the recommendation, which is to note the reports, and then we move on to the next item, which is item number 5, which is the residential and ethical care charters item. So over to you, Andy.
Thank you, Chair. Good afternoon, members. So this is an information report, agenda item 5. Originally, the request was for an update on the progress with the implementation of the residential care and ethical care charters to come to the March portfolio decision meeting. Obviously, with the advent of COVID from March onwards, this didn't occur. And so the report is coming back updated for this month, July 2020. The context for the work that we've been doing in adult social care with the independent social care provider market since March has focused very much on reacting to the pandemic, and therefore we were unable to introduce a new model of pricing for residential care in the 2021 financial year. But what we did put in place from March onwards was a financial support package for all social care providers within Portsmouth that have business with the council, focusing on personal protective equipment, PPE, increased staffing where it was required to fill any gaps left by staff that are unwell or unable to work, and a minimum income guarantee to maintain financial stability at the level pre-COVID for each and every provider that needed to draw on that support. We've additionally seen, moving into page 24 of your pack, hospital discharge guidance issued in March 2020 that I'll cover in more depth later on in a different report, which underwrote payment for residential care placements made directly from the hospital from NHS funding, which we've been accessing. It's currently unclear as to how the council will manage the strain on its finances that have been created by COVID-19, and that may impact on future work on the charters by trying to ensure stability over development for providers. That's not currently clear, and we would of course bring back any further information to future decision meetings as was appropriate. So the charters, what I've done is laid out the charters with an update for as of July, as of this month. So I propose to go through those updates in brief and then take any questions you have. So the first update for July is around commissioning of visits based on need and not minutes or tasks. Traditionally, since around about 1993, most domiciliary care has been delivered based on time purchased, because that's been a traditional unit of contracting with domiciliary care providers. We're trying to move away from that. We've had a project in play for about 18 months now, looking to move to real-time digital records, to working, moving people's care visits up and down each day, however many times a day, in conjunction with the needs that they have at that moment in time. We're not there yet because it's a very complicated thing to work through, but we are in discussion with one domiciliary care provider and a technology provider to test that on a wider part of the market in Portsmouth. And that would enable us to move away from minutes and tasks in terms of contracting for domiciliary care. That follows for the next point on page 25. We don't generally use 15-minute visits, and there's been quite a lot of coverage in the national press in recent years around that. The only time that we would use 15 minutes is if the 15-minute visits is if the customer, the person receiving the care, and the provider agree that the task could be completed in that time. Otherwise, we don't use them. In terms of travel time, travel costs and other necessary expenses, we follow the UK Home Care Association model for negotiating the increase in rates as of 2021 for domiciliary care providers. That's a body representative agency and would include associated costs within their cost model. Moving into page 26 of your pack around scheduling visits, again we come back to the domiciliary care intervention that we're engaged in at the moment, which would time visits exactly to coincide with people's needs and would avoid rushing people if that was an issue. The 0 hours contract point at the bottom of page 26. We've had quite significant discussions with a lot of our providers around it, and there's a mix both for their employees and for them as providers as to whether 0 hour contracts are preferred or not. Our concern is that if we were to not use 0 hours contracts at all, we would see an exit from a significant part of the workforce in the market because it fits in with their lifestyle, with their other employment commitments. So we don't insist on minimum hour contracts currently. Again, the new dom care intervention may enable us to shape a different model and to work in a different way, but that remains to be seen by testing that across a significant cohort of the Portsmouth market. On the base of page 27, the point about training. So during the pandemic, we've made a provider portal available to all care providers in Portsmouth, which we've sent them out a link to and regular updates. And this covers not only all the guidance that we see from the government that we think is relevant for them to keep them up to date, it also covers resources and information around training that's available that we share with them as soon as we find out about it. And if we're accessing it, we share that with them. I think I'm covering wellbeing later on, but the other thing that we've done is work with our care providers in Portsmouth for those that want to access it, to access similar wellbeing resources to those that we provide for Portsmouth City Council employees. And what we've done is made a short-term financial arrangement. So if, for instance, a care home wanted to access direct resources through our wellbeing provider, then the council would fund that in the short term to enable them to do that. Often if care homes have coped with a significant period of trauma or stress or client death, then they'd be wanting to do that. And so we're looking to support them certainly up until October with that. Moving through to the last point on page 28. We don't currently have a guarantee that all home care workers are covered by an occupational sick pay scheme. We do, the majority of the providers in the city pay statutory sick pay. There are two providers that pay slightly differently on top of statutory sick pay, but currently all providers don't pay an occupational sick pay scheme. Moving on to page 29 in your pack, I've highlighted earlier on, we've put in place a system where providers can pay for one-off payments. So in terms of maintaining adequate staffing ratios, particularly in residential care, where they've had staff that have either had to socially distance or have been in the shielded group or become unwell themselves with COVID-19 related symptoms, we've enabled providers to get further staff in from agencies or other contacts, and we've invited them to come to us for payment for one-off payments to make sure they're not financially disadvantaged for that and they have sufficient staff. As of May 2020, the government's Infection Prevention and Control Grant that was allocated funding directly through ourselves as a council into the care homes also picks up funding needs to ensure that any extra staff coming in can work within that environment exclusively rather than work between environments and increase the risk of the spread of infection. And in terms of the point care above and beyond basic tasks, the vast majority of care home providers in Portsmouth have activity coordinators or something similar that are working with people outside of their basic care needs within the environment. Moving on to page 30, there is, in terms of access to NHS services, there's a named clinician for care homes in Portsmouth to ensure that clinical and medical services are joining up in care home support. And there's also an enhanced care home team providing support, both physical and mental health, reactive and proactive, pharmacy support, speech and language, physiotherapy and nursing. And we also have quite a lot of our care homes have signed up to something called the Airedale system, so that 24/7 they can get through to a senior nurse, get some advice, understand whether someone needs to have an ambulance called for them or whether they could be treated and supported in their own familiar environment. And that gives our care home staff some reassurance that they're not just on their own making that kind of decision. The nurses at the end of that line have access to specialist consultants, and they can also contact any of the medical services in Portsmouth to assist them if they need to. The main thrust behind that really is to make sure that we're not conveying people unnecessarily to hospital. It can be extremely traumatic for people to be conveyed from a care home to hospital, especially if they've got an element of dementia. So it's trying to ensure that if they do need to go, they go, but if they can be cared for in that familiar environment, then we continue to do And then moving forward into page 33, the second row on that particular page, there's a discussion, has been for a couple of years, around pay for sleep-ins, whether it can be a single rate or whether it should be an hourly rate. This has been progressing through the courts. It's a case that's connected to the MENCAP organisation. It was heard finally in the Supreme Court in February of this year, but the judgment's not yet been issued. We see a weekly update of those judgments that are issued in the Supreme Court, so we become aware of it as soon as the judgment was issued. And if that dependent upon that judgment as to whether it's legally, whether the local authority is legally obliged to pay an hourly rate, or whether paying a shift allowance or one-off fee is acceptable. And in terms of DBS disclosures, to ensure that people don't have criminal records and are fit to work within the care industry, residential care providers in the city pay for this, and Portsmouth City Council do it for their own staff, but they also do it for voluntary sector agencies as well. That's a summary of the report, a summary of the progress on the charters. Happy to take any questions.
Thank you very much, Andy. Obviously, Jeanette is unable to take part in this item as she gave in a declaration of interest earlier. So, Graham, do you have any comments or questions?
A question initially, if I may. When do we anticipate being able to roll out the first trial of the arrangements for care provision that don't require time slots? You mentioned there was a pilot possibly to happen, but what sort of time scale for that?
We're hoping in the next calendar year. That the complication is finding the technology solution that enables us not only to roster the appropriate care, but also to bill in an appropriate way, and then linking that up with a care agency to trial that across a significantly large cohort of people in Portsmouth, that we get good results back through and can iron out any problems before we go citywide. We're in negotiation currently. We would hope the beginning of next calendar year, so January, February time. It's complicated to do this because we've got to identify an initial tranche of funding, and then we've got to move practice wholesale to this particular approach. So we want to make sure we get it right and that it works. It's, I wouldn't say revolutionary, I think that would be overblown, but it's a really different way of providing care and supporting people. And it also enables where the person receiving care wishes to have family members involved in that care and to know what's going on 24/7 for them in terms of those care visits. Which can enable us to cut out ourselves as the middle person, if you like, and ensure conversations between care provider and family, contemporaneous conversations. So it's a complicated mix to get right. We're hoping the beginning of next calendar year to see that rolled out fully.
Can I just come back on that? Have we got other projects that have already started or have been completed that we can draw on for experience? Because I know the briefing we had back at the end of last year, I can't remember, it was quite a while back, about this whole project was very interesting, and I can't remember all the detail now because I haven't gone back to look at my notes, but is there anything that we can draw on from other attempts to introduce this across the country, or maybe even other countries?
We did a very small pilot ourselves where we contracted directly with the care provider who we brought in and we managed directly, which you'll remember from that update. There are some examples around the country of where they've done this type of thing, but it's peculiar to the local area. You've got to get it right with the providers you're working with. So whilst we've taken lessons from that, it's the actual mechanics that means that we haven't moved forward as quickly as we'd like to. And I mean, COVID hasn't helped with that, having gone into response mode. There are some examples. Other countries, I believe there are some examples from Holland. They have that kind of way of doing things, but it's really getting it right for Portsmouth that's meant that we've needed to take time. But there are some examples of that in operation, and we can. I mean, I can come back with some more detailed information and do a briefing if that would be helpful.
Yes, that would. Thank you. Yeah. Just a couple of comments, if I can, briefly. I noticed the reference to the living wage, but I think there's potentially a bit of confusion for people who don't know this, but there are two elements of living wage. There is what's called national living wage, which is effectively the minimum wage rebranded by the government to be called the national living wage. And there is the living wage, which is the living wage foundations standard, which is different and higher. And I think the charter authors are referring to that when they talk about living wage rather than the national living wage. So it might be helpful to make that a little bit clearer that there are two different ones, because I know when you read it, it's not always clear. And the charter authors are actually talking about a different version. The other point about statutory sick pay is interesting, because there was also one comment there, and I can't remember exactly what it was, which said that permanent staff are employed in care homes are sometimes on something more than statutory sick pay, but not all of them. And in a sense, this has raised an issue which I think we've become familiar with, where care workers, for various reasons, feel sometimes unable to take sick leave because of the poor remuneration from statutory sick pay. Now, obviously, the COVID situation is quite different. I'm sure care workers wouldn't deliberately put their clients at risk by coming in if they were ill. But people who have maybe a physical problem like a bad back or whatever will often be encouraged to come in and not take time off because they just can't afford to. So we do need to find ways of moving away from something that is just actually to more effective remuneration. So low-paid workers aren't forced to come in when they really probably shouldn't do, and damaging their own health. That's the other point. I mean, I recognise, obviously, with the current COVID situation, it's been difficult to make progress on this because of the situation. But I think we've got to recognise that whilst the viability of the care sector is really important, we also need to make sure that going forward the workforce is properly looked after. Because I think we've realised how absolutely valuable they are and what a tremendous amount of work they put in under extremely difficult circumstances. So I think we need to, on top of trying to get the care providers to give their workforce decent remuneration and decent conditions. Obviously, that depends on a different funding system for care as well. But you know, I do recognise that's something we need to keep up with. So that's really all I wanted to say.
If I might just come back on that, I think what our intention is around the charters is to work with our local provider representatives who we meet with very regularly to see if we've got any room to manoeuvre in terms of bringing forward those parts of the charter. So I think there's an intention to do that. It's the challenge is going to be the financial envelope, I think, that we see post-COVID. And you're absolutely right. We've been asking for a sustainable funding solution for social care for some time and had a green paper that hasn't appeared on several occasions. So those two things are absolutely linked.
Okay, thank you.
Thank you, Graham. And thank you very much for the report, Andy. I think it's unfortunate that the update we were hoping to have by this stage isn't possible because of COVID-19, and that a lot of the things that we had in train that were going to really move this forward would have moved this forward in the last 4 months of not being able to happen due to COVID-19, such as our new way of working with domestic care and also the working that we've been doing with residential care providers. So one thing I do think that out of COVID-19 has come on is that our already improved relationship with our residential care providers has come on even more. And I know me and you, Andy, as well as others, are on a meeting later on this afternoon for our fortnightly meeting that we're having with care providers to make sure that they're really connected in with the council, which I think has made a huge amount of difference. And as both Jeanette and Graham are aware, I think there's some real potential for really being able to move forward with these charters with a greater amount of real optimism with those ever closer relationships we've got, and of course how it all fits in with the greater health and care system. Obviously, there are some bits of it that we're waiting on, such as the Supreme Court decision. And Graham, again, is absolutely right in terms of the living wage as defined by the Living Wage Foundation, which I remember when we were in opposition. Before both Graham and Jeanette were on the council, we were in opposition. We were doing motions to council about that. We had to always make the point that we weren't talking about the national living wage. It's the living wage as defined by the Living Wage Foundation. But unfortunately, in the actual charter itself, it doesn't make that massively obvious. So I know that within the report back, we're just effectively taking each point as is in the chart. But no, thank you very much for that. And I do see this as something as a living document. So having updates on a regular basis, so I'd certainly be looking to have another update in this before the end of this financial year for the charters, and hopefully by then we'll be through the end of COVID-19. We'll have more information and stuff about the tech, and I know that we've been discussing ideas with Southampton University. I think Andy was the university where they had the tech that we used in the intervention in the pilots. And if we could move that forward, that'd be fantastic. But as with these things with technology, it's about interfacing it with and having the licenses to interface with lots of different bits and pieces. But if we could get that moving, I think that would make a real sea change, both for as Andy said, we'll have a report back on that anyway, but also in terms of being able to deliver across all care providers, all domestic care providers, in adherence with the domestic care charter. So I think that'd be a real advantage for that. So thank you very much for the report, and I say look forward to another update before the end of the financial year. And I note that report. So thank you very much. Okay, so if we move on to agenda item 6, adult social care charging arrangements. Over to you, Richard.
Good afternoon. Thank you, Chair. So the purpose of this report is to respond to the motion adopted by full council on the 14th of January this year, which sought the Cabinet Member for Health, Wellbeing and Social Care to investigate the introduction of a daycare cap for all social care client groups and to advise councillors on the financial cost of this. At the full council meeting on the 11th of February 2020, it was suggested that any financial cap could be reinstated at £250 per week in respect of daycare, community support and health and independence services. However, that any reinstatement of the financial cap would be conditional upon the legal opinion confirming that the implementation of such a cap is not discriminatory in law and that clients with a protected characteristic will not be determined to be treated unfairly. So section 4 of your report sets out the legal powers for charging under the Care Act, but I don't intend to go through that section. I'll move on to section 5, and section 5 of the report sets out the current financial assessment methodology, and there's a few points I'd just like to pull out from that part of the report. Firstly, where the council decides to charge for services, it must follow the requirements of the Care Act and the related statutory guidance. Capital thresholds and the minimum income guarantee values are set nationally and are not a local decision. The current upper capital threshold is £23,250, and this means that any client with capital above this threshold is considered as having the financial resources to meet the full cost of services. Where a person has less than the upper capital threshold, a full financial assessment is completed, and an example financial assessment is shown at the top of your pack on page 39. If after deducting allowable expenses and the minimum income guarantee value from the client's total income and there is a remaining value, this is considered to be the client's disposable income and would constitute their maximum weekly assessed charge. Clients are charged either their maximum assessed charge or the actual cost of services, whichever is the lower amount. Section 6 of your report provides information on the financial and administrative impact of reintroducing a financial cap. As at February 2020, 90% of the adult social care clients in receipt of daycare, community support and health and independence services were either paying nothing or contributing up to £60 per week. Of the remaining 10% of clients, 7% were contributing between £60 and £100 per week. The table at paragraph 6.2 shows that 4 clients had financial contributions in excess of £250 per week. From an analysis of the financial assessments for these clients, the reasons for their current level of contributions was due to the combination of the level of services that they're being utilised by those clients and them having capital in excess of the threshold of £23,250 that I mentioned earlier. The table at paragraph 6.4 shows the potential cost to adult social care as a consequence of lost income if the financial cap were to be reintroduced for the daycare, community support and health and independence services. Whilst the table at paragraph 6.6 shows the financial impact if the cap were to be applied across all adult social care services. If the financial cap were to be reintroduced, then adult social care would also need to identify and implement alternative income or saving strategies in order to maintain a balanced budget and offset the impact of any lost income in both 2021 and in future years. Section 8 of the report provides more detail on the options for consideration today. There are three main options available: maintain the current charging arrangements, reinstate a financial cap for specific services, or reinstate a financial cap on all adult social care services. When considering whether to reintroduce a financial cap, it is necessary to ensure that the approach to charging is also consistent with the Care Act principles, which include that charging rules are applied equally so that all those with similar needs or services are treated the same and minimise anomalies between the different care settings, and that it be sustainable for the local authority in the longer term. The recommendations contained within the report ask the Cabinet Member to consider and approve, as I say, one of the three options. And if a financial cap is to be reintroduced, the Cabinet Member is also asked to confirm the level of the cap to be applied, that any financial cap is implemented on a temporary basis as set out in Recommendation C, and that the Chief of Health and Care Portsmouth is asked to identify and implement alternative income or saving strategies in order to offset any lost income. That's it. Happy to take any questions.
Thank you very much, Richard. Graham, shall I come to you first on this one? Any questions or comments?
And no specific questions. I think we've covered this before in the briefing, so I think we've probably covered all the answers. Just question what the recommendation is going to be, because we don't yet know what it's going to be.
Okay, Jeanette, any questions or comments?
My only sort of comment and concern is any decision made, the impact on budgets, and going forward with COVID, budgets are really unknown at the moment, and how much we have to save because of all the money that we have actually spent out on COVID. So having said that, though, this is a bit of a drop in the ocean, and we've got to be mindful that we're not affecting just a handful of people, rather than trying to make it as fair as possible across the board. So it's a difficult one because no one's got a crystal ball, but I'm not clear, like Graham, Councillor Heaney, on the actual recommendation that's going to sort of go for. So I'll reserve my judgment on that one.
Okay, thank you very much. So this is obviously referring to the motion that we had in February, and this was also in regards to a decision that was made originally by myself in 2018, the end of 2018, and it was referring to the charging and the cap being lifted. At that time, the information I had didn't cover the potential amounts that people could be charged up to. That we only had some of the charges that ended up being done were far higher than in the report at the time. So that was a bit of a surprise, and obviously that had an impact on some families in the city. At the same time, when making that decision, it was with the understanding that it was already 1 year overdue at that time that we would have had the information from government about a new charging for adult social care across the country. Unfortunately, we're now 3 years on from that original disposition in 2017, and unfortunately we still have no end in sight on that. Indeed, the Prime Minister, just after the election last December, alluded to the fact a plan will be put forward by the end of this year, but it will likely not be until the end of this Parliament that any implementation of that would be. So therefore, the huge increase for the people who have had their cap lifted for these services is going to be with them probably for at least another 3 or 4 years. On that basis, and as I alluded to at the full council meeting in February, I will be looking at reintroducing a cap only for those services that previously had a cap, and that I will place that cap at £250. During the full council meeting, there was some members, neither of whom are present, none of whom who are the two present here, other than myself, who were talking about capping all of adult social care. But as you can see, even if you put the highest cap down we've got on the papers today, that would mean that it would cost the council more than £1.5 million, and therefore, as we can see, that is completely unsustainable for the council, but also goes to show why we really do need a proper funding settlement and properly funded adult social care from the government. But that is in the government's hand to do, and they have delayed doing it. As a result of the meeting in February, I did also have send a letter to the Secretary of State for Health and Social Care, Matt Hancock. Unfortunately, so I didn't get the letter back until just over a month ago, and it pretty much said what the Prime Minister has said back in December, which was they're coming up with a plan by the end of the year, but there will be no. But it didn't even say anything about implementation. So this is extremely frustrating for families in the city. This is a far wider issue than just these charges, but I do think it's right that we reinstate a cap for those services, and it will be in place until such time as we get those new funding arrangements from the government. But I fear that might not be for another 4 years, which will be really not good enough. But it's a very difficult place. I would love to have a cap of £60 for the whole of adult social care, and for that to be funded by government. I think that is what should be equitable, or a cap of some kind for all adult social care. But that's not where we are now, and we have to remember, especially in these straitened times for council finances, that we are doing something, but we can't do everything that we would really ideally like to do. Okay, so that's my decision on that paper. Okay.
Councillor Winnie, sorry, can I just double check to make sure we're clear on the decision?
Please do. Yes, please do. I know there's a few. It's not the most straightforward. I know that. Yeah.
So in terms of recommendation A, I'm assuming you want A2, just to clarify.
Yeah, let's just get it up. Sorry. Yes, that's right. Yeah, recommendation A2, and within B that will be £250. And recommendation C, obviously yes, I adopt that as well, that it will be until such time as we have the change in the reform that the government has promised for the last 3 years, that will come in for adult social care in terms of funding and capping, etc., on a national basis. And then obviously recommendation D as well, that the Chief of Health and Care Portsmouth will identify alternative savings or income to cover the £17,000 that it will cost the council.
Okay, thank you.
Okay. Thank you very much. I think we've lost Anna again. Yes, we've lost Anna again. We'll just pause until Anna re-emerges before we move on to the next agenda item.
Yes, apologies, Chair. I dropped out of the meeting again. I've got back in it. hear anything. I dropped out. I had to get back in. I can't hear anything. I can't hear anything.
Anna,
Mm.
it's Helen. Just to
Hello.
say, Andy's put a message up that we've lost Councillor Willington. He's now dropped out. But we can hear you, and we were just being quiet because we were waiting for Councillor Willington to come back.
I've dropped out twice. It's an occupational hazard at these meetings. Yeah, I've seen Andy's message here. If we just pause a few moments and give him a few more minutes, and if we may have to have a short adjournment while we try and see where he is.
Okay, that sounds sensible.
So I haven't missed anything since Richard Webb last spoke with clarifying the recommendations.
No, that's where we stopped. Anna.
Right, okay. I think if everyone goes on mute while we try and get Councillor Winnington back, and if we just pause for a few moments.
Apologies all.
That's very worrying. Welcome back, Councillor Winton. The problem is we had Anna, and just as you came on, she seems to have dropped off again.
Yeah. Okay. Well, as the last two reports are only for noting, I think if we just crack on with those. So, yeah, if we start off with, sorry, I've lost my agenda now because I had to reboot my laptop.
It's the ASC response to COVID-19.
Okay. Yeah. Do you want to go first, then, Andy? Over to you.
Thank you, Chair. Afternoon, members. So this is agenda item 7, the adult social care response to the COVID-19 pandemic. So again, we were anticipating bringing something back to the March decision-making meeting to give an initial update on the response to the COVID-19 pandemic. But obviously, as we've discussed, there were different arrangements made and the Council moved to critical services only. So I've summarised some of the key issues in the following report. It was difficult to get them all in and keep the report in some kind of reasonable length because of the fast-paced nature of the change and all the minor changes that happened in between times, but I've tried to cover the main areas, but happy to take questions at the end. Most of the direction for adult social care has been in response to guidance that's been issued by the government since March 2020. This is essentially because, broadly speaking, adult social care as a function is governed by the Care Act, Mental Health Act, Mental Capacity Act, so is governed by 3 statutory pieces of legislation and by guidance that's issued from time to time in relation to those. We had a business plan, business continuity plan, not specifically for COVID-19, but in terms of pandemic, to maintain staffing in core provided and purchased services, and to understand those people in the highest priority need if we needed to limit or ration services. And this was pre something called the Care Act easements being brought in, which I'll come on to later. So what we did when we understood the initial nature of the pandemic was that we closed or reduced non-critical services and redeployed our staff to support critical services, for example, within residential care, and the emerging work for people that were in the shielding category, the extremely clinically vulnerable category. Moving through onto page 60 of your pack. So our priorities focused initially around personal protective equipment, PPE. There was a very significant amount of national coverage and continues to be around the supply of PPE, initially to the NHS, but then latterly to the care sector in England. And we worked with our Locality Resilience Forum, Hampshire Isle of Wight Locality Resilience Forum, to firstly establish a strategic reserve at LRF level and then to establish a strategic reserve at Portsmouth City Council level, with the intention of being able to supply our own patch plus make emergency loans if we needed to the Resilience Forum strategic level. I'm happy to say that going from covering just the initial 24 hours if somebody was running out of PPE or a provider rather was running out of PPE in Portsmouth, we're now able to supply past 48 hours for people due to purchasing and ordering that we've made as a city council. We appointed an officer with a team behind them to ensure that we could supply any care provider in Portsmouth with PPE. We saw the publication of government guidance on hospital discharge, and I've included a link in the report that was published in March this year. And that directed us to work with NHS partners to enable rapid discharge from hospital. This was very much considering the anticipated impact on NHS acute capacity for those that needed ventilators, oxygen therapy, etc. And so was geared really towards moving those people out of hospital that no longer needed acute care in a very short time frame. 3 hours was the guidance from being declared medically fit to being discharged. So we worked in the initial phase with NHS partners to identify both domiciliary care placements and care home placements for people to be discharged to. And then further on into the pandemic, stood up extra resources in domiciliary care for people and started to work to establish a unit at Harry Sotnick House, which I'll come on to in a moment. The Coronavirus Act became law in England on 25th March, and that contained an ability for us to ration care in effect. That was to implement something called the Care Act easements. which would have required notification to Secretary of State and local members of Parliament. I'm glad to say at the moment that we've not had to apply those easements, and whilst we keep the situation under review, if at all possible, we wouldn't want to apply those easements because we want to continue supplying a basic level of care for everyone that needed it. Moving on to 2.3, care homes. We've seen, as you'll be all too aware, very sadly, that many care homes have experienced the death of residents with suspected or confirmed COVID-19 from March and slightly before onwards. This has been no different for those care homes run by ourselves and others in the city. It's not unexpected. It's an airborne disease that's easily spread, but it doesn't take away the impact that every death has on family and the care home community and the staff working. We introduced some fairly strict infection prevention and control measures in our care homes, using all the guidance that we could gain access to, and our local public health colleagues who are overwhelmingly supportive, enabling us to manage the spread of infection in care homes and care for people in isolation. We then saw in April the Social Care Action Plan covering 4 main areas: controlling the spread of infection, supporting the workforce, supporting independence, and supporting local authorities and providers of care. Moving forward onto page 61 of your pack, part of this action plan obliged us to secure alternative accommodation for people who were going to be discharged from hospital but needed care in a care home. The care home estate is in very variable states of repair and ability to provide isolation care, which was the recommendation on discharge from hospital, even if someone had a negative test for COVID-19. And so we established a unit at Harry Sotnick House after considering several options locally in the city with our NHS partners. There's been commentary locally around Harry Sotnick House and evidence around enabling people to be cared for in isolation in a single unit with a separate entrance, lifts, etc., etc. And that was operational from the 1st of June of this year. We were also required, moving to the middle of the page, to produce a care home support plan covering PPE, workforce support, clinical support, and very much showing the join up between the NHS and the local authority in providing care and support to our local providers to enable them to provide care and support to the people that are their customers. That's published on our website, as we were required to do, and I've included the link there for further information. Part of that plan was a distribution of a grant that I referred to in an earlier report around infection prevention and control that was passported straight through from the local authority to care home providers. And we're working with care home providers as to how they use that to control the spread of infection in care homes. I referred earlier in talking about the charters to the provider portal to ensure that as far as possible all providers were able to access a data point that would inform them of the latest government guidance, anything that we saw that we felt was useful in terms of training, education, infection prevention control, and we continue to publish items on the provider portal and remind people of the link. We have weekly virtual meetings with our NHS colleagues with care homes, providers in Portsmouth. We have a fortnightly meeting with providers of domiciliary care, and then regular frequent meetings with providers of daycare and supported living, purely to provide a Q&A session to answer any queries, to understand what's going on for the sector, and to try and keep in touch and see the provision of health and care Portsmouth rather than the provision of individual organisations. We also, as I touched on earlier, put in place a package of financial support that focused on PPE costs, increased staffing, and the minimum income guarantee. Essentially to understand that if a provider was in receipt of a certain level of income in the 3 months prior to the COVID-19 pandemic, they wouldn't fall below that level of income. That guarantee is still in place, although it will begin to taper down between this month, July, and October of this year. In terms of testing, which is the final item in the report, we've seen, as with PPE and care home support, an emergent issue with testing throughout this pandemic. It was very limited initially, and if a care home had 2 or more residents, then testing could be arranged. QA then started Queen Alexandra Hospital then started to share their testing facilities with social care staff, which was really helpful. And then we saw the drive-in testing site at Tipner, where we were able to refer to staff to. Subsequently, we've seen both postal testing available and whole care home testing available to care homes who register on a testing portal. The most recent development as of last week from government is that whole care home testing of staff is required to take place weekly and residents monthly. Because it was only announced last week, we're just getting to grips with the logistics of that and how we help care homes do that safely and responsibly. And so we're going to understand that over the next week or so, but it's as of this week that started. As I say, that's not everything that's been involved in the ASC response. We've had fantastic support from council colleagues. I think we've had some really good feedback from our independent providers and excellent support from our public health colleagues, but I'm happy to take any questions that anyone has.
Thank you very much, Andy. Jeanette, you wanted to come in on this?
Yes, thank you. Actually, it's a comment because it's a question to the chair rather than to the officer because they can't answer it.
Yeah.
Bearing in mind the Prime Minister's comments yesterday on the care providers not following instructions, which caused 20,000 deaths, could the chair sort of give your opinion on that comment and how the response and Andy just touched on it at the end there about the link between the private sector and the public sector and how well we did in Portsmouth, because I think it was an amazing response, but I'd like to get your views on that.
Thank you, Jeanette. No, I think the Prime Minister's comments yesterday were absolutely disgraceful. And actually even worse was the comments of the Secretary of State for Health and so-called social care, because he was gutless in trying to mitigate the response and try to say he didn't say what he meant to say. And I think I've literally just been reading the article again now because I thought this might come up today, and it's just a litany of blame shifting. I think that the response of the government in general was very poor. I mean, the reason why there would have originally been a paper on this coming to the March meeting, even right at the start of the COVID-19 pandemic, was because the adult social care team here, with NHS colleagues and with care provider colleagues, have been working on our response in adult social care in the city for weeks before the lockdown came. So we were in a position where we could do a response. So I completely agree that the response locally has been absolutely outstanding, and the work that we put together. But it was because effectively there was no guidance. There was very, very little in terms of how local councils should interact with Solent, as it is in our area, and the care homes. But we got in and did that early anyway, and that really has had the response that though we have had care home deaths, which is very sad, and I wish that could have been avoided. But we have got one of the lowest, 140 out of 150 local authorities for COVID-19 infection rates, and we've got a very for infection rate and also very low for death rate as well, and that really is a tribute to the work of staff at the council, work in the local NHS, work in all the care homes and dom care providers in the city, because without that we would be in a much worse state. But it just shows that working together and breaking down those silos between the different organisations really has that. But to shift blame from what was utter chaos, a day by day, the information from government was changing. And if we'd just gone by that, if we'd been one of those authorities just that wasn't in a position to effectively pre-plan what we were going to do, we would have been from pillars to post, and we would have been in an utter mess, which some authorities unfortunately got into because all they had the capacity to do was go with what the government said. So it's really, really frustrating. Well, actually, it's worse than frustrating. It's criminal, really, that they should try to shift the blame on care homes who have been, the people in care homes who have had deaths in their homes and people ill in their homes have had a horrible, horrible time, really awful time with it. And they deserve all our support, and they deserve all politicians' support, right to the very top. So for them to get the slap in the face that you didn't follow our procedures right is just dreadful, absolutely dreadful.
Thank you for that, Chair. And I obviously echo everything you've just said. I think the public need to hear that. And I would like the administration to put out a complete rebuttal on that. And that's also saying about the good work of all the officers involved, the staff involved, the residents involved, the relatives that have been involved. And I think they need to hear that positive message, not the rhetoric from the government who's just trying to shift blame.
Yeah, and that is my intention today to do that, not just here but also via other sources as well. So I assure you that will be the case, Jeanette. Graham, did you have any other questions or comments, Jeanette?
No, thank you.
Okay, Graham.
Well, I thought this issue might come up, so I'm going to ask a question. Do we have any evidence that either private sector...
Oh, you're on mute, Graham.
Hear me now? Is that okay? Right. Sorry, I thought this might come up, so I'm going to ask a question. Do we have any evidence that either private sector care homes or the public sector care homes in Portsmouth did not follow the guidance that was given by government, in any significant extent? Do we have any evidence to support that claim? And secondly, were there set issues around the clarity of the guidance as it came out? I think you mentioned, Councillor Wellington, that there had been changing advice. Was there a lot of changes which made it difficult to follow the guidance as well?
I think what we saw in relation to the guidance, particularly around PPE, was a very frequent updating of it, and we saw it positioned in various pieces of guidance. So we had things entitled caring for people safely in care homes, caring for people safely in their own homes, and then PPE guidance moved from that and came into its own, and then it was relinked back to that. So we saw a constantly developing picture around guidance. Now, part of that would have been driven by the phase of response that we were in as a country in terms of continual transmission in the community. And part of that would have been driven by developments in terms of where the level of threat was seen to be the greatest. So I think we saw a continual updating of guidance. It was very difficult for providers to keep up with. If I'm being very honest, having spoken to providers and had lots of discussions with providers, I think what we tried to do in Portsmouth particularly, and it echoes really what you've both just said, because of the nature of the working relationship with the NHS, not only with Solent NHS Trust, but with the clinical commissioning group, we have very close working relationships. And so what we were able to do was, for instance, before we put our care home support plan in, the national one we were requested to do through the Social Care Action Plan, we were already working on one with our colleagues in CCG, Solent NHS, and in fact in the Portsmouth South East Hampshire wider health system as well, and our public health colleagues locally. So what we tried to do was respond to any confusion or concern providers had and share with them the latest guidance to enable them to make sense. But it was an extremely rapidly developing situation. I see Helen's hand is up and she's probably far better qualified to talk about PPE than I am, so I'll pause there for a moment.
No, Andy, actually, I wanted to fully agree with you. I just wanted to put this into a context, which I don't think anyone's mentioned, that this is a novel virus, so it was a completely new virus. Therefore, the research was and the evidence was actually developing very, very quickly, particularly at the beginning. I just think we need to put that context, because obviously the understanding of previous pandemics was based on the knowledge at that time we were, Public Health England were pulling in the international evidence from Wuhan, from China, from other areas. So I do think it's really important to note some of the change in guidance was because that greater understanding. So that has happened all the way through, but particularly at the beginning of how we would normally manage a virus or an outbreak in a care home and in a hospital setting in terms of use of PPE. That was changing quite rapidly at the beginning. So, and I'm going to say, I think Andy and the team working closely with the public health and the local health protection as we're adapting, particularly working with IPC and the infection prevention control function at the CCG and Solent very quickly to ensure that we were adapting very, very quickly. So I suppose if you're looking for evidence, I would say that there's good evidence in terms of how the speed at which we were adapting and ensuring through and I think you have more than one a week, don't you, Andy? Meetings, webinars with the providers, your providers, but also because that's really important. So as the evidence was adapting, changing, we were ensuring it was in place. But I suppose the greatest evidence to use is, did we have a lot of outbreaks and were they managed effectively, and have we therefore reduced? And if you look at the hard data in terms of the evidence, we had a number of outbreaks at the beginning that were managed very effectively to move into us not having had an outbreak in any care home in Portsmouth for several weeks now, I think. Is that right, Andy? Although we've had the odd case that has confirmed new case that has come out of the whole care home testing, we haven't had further spread or outbreaks. And I suppose that's the most effective evidence you can use in this situation.
Can I come back on that? Can I just say thank you for that.
You're on mute again, Graham.
Right. So I was going to say, just come back on that, and I think this is a huge tribute to the staff in the local authority, Anthony's team and other staff, and also the care home staff in the city who responded to a quite unprecedented situation and did it flexibly and did it, it seems to me, to try and do the best they possibly could to secure the welfare of residents in care homes. I don't think there's any doubt about that. So I don't think there is any evidence that care homes didn't follow the guidance in the way the Prime Minister said yesterday. I have to say, I thought, I'm going to make some political comments there. I think the comment he made yesterday's were absolutely extraordinary. I couldn't believe that he suddenly made this off-the-cuff comment about care homes in the middle of an interview about, the general situation. And I don't know what evidence he had for that statement. And he seemed to give no thought to the potential, shock and also, I think, dismay that would be caused by what appeared to be a rather off-the-cuff accusation. But I have to say, it's not the first time that the Prime Minister has done things like that. He's done it in his past as Foreign Secretary with certain consequences which we may well be aware of. So I do hope we do respond to this and say that, we will congratulate our staff and that there is no evidence that care homes in the city did not follow guidance that was put forward to help look after people. So I do think we need to challenge that. And I do hope the Prime Minister will reflect on what's happened and consider apologising for what he said, because I do think it's caused a lot of upset, and quite understandably so.
Thank you, Graham. Yeah, and I will be I'll be writing to the Prime Minister and the Secretary of State to say that that they should apologise and that the care home staff should be lauded rather than castigated for their own failings. So thank you both for that. And Andy, just thank you for the general report. I think the thing that really comes out of there is that the huge amount of hard work that's been going on right across adult social care, and the way not only that they've carried out their work, normal work, but also the staff who have been helping out in other areas of adult social care. and helping out there, and people who have been working from home, which sometimes was not the easiest or best way for them to be doing their work, but managed to adapt and do things differently. And I think that's a real tribute. And in the end, they've maintained a service that is there specifically for the well-being, the support and well-being of some of the most vulnerable in Portsmouth. And the fact there's so much in this report, I think really goes to show the work they've been doing in partnership with other parts of the council, with the Hive, with other organisations in the city as well, which I think is an absolute tribute. So my thanks go to you, Andy, and then everyone in adult social care for their work.
Thank you, Chair. It's appreciated.
So I'm very happy to note that report. And then finally, we're on to agenda item 8, which is public health's COVID-19 update. Over to you, Helen.
Thank you, Councillor Willington. So on your pack, we're on page 63. And this report, again for information, as in the adult social care, really gives an overview of the work that public health have been doing since the beginning of the pandemic. It's fair to note that public health probably in terms of the response started slightly earlier than most of other parts of the council, as we had to start the local resilience forum process as we went into a major incident and chaired the SCG. But to give the background paper, this covers quite a lot of areas. It starts with the role we have played within the council to ensure that we set up a public health rota that other areas of the council could approach via email or telephone to give specialist advice, and we supported HR around interpretation of the national guidance into our own HR plans for staff, which covered areas like PPE, social distancing, how we would do home visits to residents, volunteering, and also supported and worked alongside our colleagues in the CCG in Solent around infection control, advice to care homes, schools, sheltered housing, and our homeless accommodation. We also work very closely through, and I'd like to mention in particular Cheryl Scott, who is in our communications lead for public health. She has worked tirelessly throughout this process, ensuring that we had both the best and most up-to-date information in on internal for our intranet site for staff, but also externally facing communications. Now, you'll remember, just to put a context on that, at the beginning, as we've just discussed in adult social care, the guidance was changing rapidly, particularly at the beginning in terms of travel and the requirements as people were returning from high-risk countries. So that ensured that we had to make sure that our data and information on both the intranet site and our external website was always up to date, which we worked very hard to do. And then moving on, which now moving into page 64 of the report, also then mentioned the work we've been doing. So as well as the internal facing work that we've done leading in terms of the specialist advice within the council and to partners, we've also been working across the Hampshire and Isle of Wight Local Resilience Forum, ensuring that we had a consistent and coordinated response. So we've worked to ensure that the directors of public health, both for Hampshire, the Isle of Wight, Southampton, and myself and Portsmouth, have worked together and taken the lead in certain areas. And I myself have led around public health input to the health and social care cell of the local resilience forum, as well as chairing the intelligence response into the recovery coordinating group, which is chaired by the chief exec, and the other DPHs also took a lead. So particularly mentioning Debbie Chase, director of Southampton, leading around the work of the modelling cell, and Simon Bryant, DPH for Hampshire and also the Isle of Wight, his role as the Deputy Chair of the Strategic Coordinating Group and also his lead around preventing spread. This has just meant that we could actually, in quite limited resource, ensure that we were covering greater areas, so that we did take that approach across the whole of Hampshire and Isle of Wight, particularly around our intelligence and the work we've been doing around the modelling cell, and in terms of the specialist advice around agreeing the approach for things like PPE across the whole of Hampshire and Isle of Wight. I won't go into the detail, but it also lists the different groups that we have been taking the lead for across, and our staff in public health in Portsmouth who have been working across the whole of Hampshire and Isle of Wight to ensure that we could really cover all the bases in terms of that specialist advice. We also worked across the region, so there is as you'll be aware, there is a National Association of Directors of Public Health, as there is a National Association of Directors of Adult Social Care and of Children's Director of Children's Services. So we work quite closely across the South East region and have taken the lead in different areas. But that has meant that we've also then received a great deal of work across that other Directors of Public Health have led in their patches. So we specifically took the lead in the work we're doing around the recovery and looking at both the modelling data, intelligence into recovery, but also some of the policy changes, and also looking at the research of what is most effective in terms of response, in terms of recovery. So we've done quite a significant piece of work around looking at the international evidence from other pandemics, but also of other parts of the world and how they have moved ahead of us into recovery where they have been earlier. And also I have sat, which has been very helpful for us in terms of receiving the most up-to-date information and what's happening next. I've sat as a National Association Director of Public Health representative on the whole care home testing national task and finish group, which has been incredibly helpful for us to find out what's actually going on early and being able to adapt to that. So that's a little bit of the work we've done across the LRF. And then finally, when I'm moving into page, or not finally, just before finally, I wanted to mention specifically the work that we've done around public health intelligence, working both in Portsmouth but across the Hampshire and Isle of Wight, because I do think we have been leading the way in terms of the work across the region to perhaps be a little bit, blowing our own horn, because we've actually worked very effectively. We're one of the few areas that when the national SAGE intelligence around modelling wasn't shared, that we then started to produce our own work locally, and not many places across the region have done that. So we've been working since the beginning on our own modelling. So we produce that work as a reasonable worst case scenario, which goes to the Strategic Coordinating Group, the SCG, now on a fortnightly basis. And it's fair to say, although it's been a lot of focus on that and the R values, we've generally pretty much R scenarios to date, and we've got 3 scenarios that have been modelled against a R value of 1.3, 1.2 and 1.1. That work has been used to prepare statutory services in Hampshire and Isle of Wight for wave 2, which is currently modelled for late October, November and going into winter. So that modelling work is being used for the NHS to prepare, as well as other statutory services in Hampshire and Isle of Wight. We've again, which are the 2, you've got 2 appendices we've provided to give you examples of the work that our team have led. We have produced in Portsmouth, led by Matt Gummerson, a Portsmouth Gold dashboard, which is produced, and there's that's Appendix 1. Attached is, as an example, which we produce every week and is taken both to Gold, which is the Gold, which meets 3 times a week, which is basically the Portsmouth City Council's corporate response to COVID-19, and we produce a dashboard that goes every week. That dashboard is also used for the now newly formed Health Protection Board that meets every Friday, but also the data and information is shared with the Engagement Board, which, as you'll be aware, the Member-led Engagement Board which assures the work that we do in the Health Protection Board, which meets monthly. So again, we've also produced recovery timelines, but also kept up to date through the intelligence cell the information that goes to the recovery coordinating group each week, which does the policy updates as well as any evidence around recovery. And then finally, going in now to the arrangements we've got in place for the test and trace, and the requirement that we had to have in place local outbreak plans by the end of June, and the governance around framework around that with a local health protection board and a member-led engagement board. And again, we met all of the requirements by the end of June and submitted our plan into region last Tuesday for the deadline, and also have undertaken the national survey that was required by the National Assurance Board, and we are now members of the Regional Assurance Board, which meets weekly, and are just waiting for the next steps and process moving forward. So again, in the report on page, which describes in page 67, and as we go through, it explains the arrangements for how we will work, what the main areas of the outbreak planning are around the 7 themes, which include the governance, contact tracing, testing, but also the areas of most focus like schools, care homes, our homeless hostels and other high-risk settings. And then finally, we've included there the requirements around the governance and the membership and main roles of the Health Protection Board and the member-led engagement board. And that brings me to the end of the report on page, with the structure on page 71. We also mentioned just in there the relationship from the local upper tier local authority leadership around outbreaks and the work that we'll continue to do on the local resilience forum, specifically around testing, intelligence and communications. And that's me.
Thank you very much, Helen. Graham, I'll come to you first this time. Any questions or comments?
Just one quick question. We had some issues earlier last week about data sharing between the testing service and local authorities. Have we got any issues or problems with that, or has that all been resolved and we can effectively share data?
Yes, so in terms of the main issue was our access to the national, particularly the Pillar 2 and the test and trace data. So you'll be aware there's been quite a lot of national coverage in the media about this. So because this all hit at the beginning as Leicester went into their local lockdown arrangements, and there was quite a lot of discussion. So we had been waiting for, and I think many occasions when we've been meeting, I've said we're still waiting for access to what we'd call the more granular detail data around test and trace and Pillar 2 testing, but specifically around postcodes, so that although we had access to the number of confirmed cases for Portsmouth, what we didn't have was the detail of the postcodes, so we didn't know where those cases, confirmed cases, were, which is very difficult. You can't really do outbreak management if you don't know where your confirmed cases are. So we, the week actually that Leicester, so 2 weeks ago now, we were provided with the arrangements that we would need to put in place to sign a local data sharing agreement with Public Health England to get access to that data. We completed that pretty quickly. It was the normal protections around information governance and holding personal data, and we are now accessing that data on a weekly basis. And interesting, just by note, we've just also been approached by NHS Digital to make arrangements so we can get access to their data. So that's really important. We are now getting that, and we are reporting that in our gold dashboard on a weekly basis. And just to give you a bit of detail on that, so I get a daily now reading of Portsmouth. So just as an example, in the last 7 days, and that's of today, the 5th, we have had 3 new cases in the last 7 days of which one has come from Pillar 1 and 2 from Pillar 2 testing. So Pillar 1 is the hospital, it's the acute laboratory testing, so it's basically for staff and patients. And Pillar 2 is the community testing, so that includes the home testing that Test and Trace do, as well as our tetanus sites, as well as any of our whole care home testing from care homes. And we've had no outbreaks in the last 7 days. So that gives you a kind of flavour of the data that we're getting. I can also see how many cases have been referred on a weekly basis and sometimes daily to NHS Test and Trace, how many contacts were identified and how many of those contacts have already been followed up. Now, the one thing that I would mention, because I think it's quite important since we last all spoke, is that nationally, the data for Pillar 2 has been added to the daily national dashboard. So we already saw that in terms of the overall numbers of confirmed cases, but what we weren't getting is that added to our local upper tier local authority data. So to give you an example, that took us in 1 day, but it was just because the reporting started to be included. And it was data that came in from the beginning of the pandemic. So we went from 325 cases, confirmed cases, to 493, and our rate per 100,000 from 151 per 100,000 to 229.2. So that looked, if you didn't understand, in fact, we did get quite a few queries via our social media Twitter account, which we replied to, just showed it looked like we'd suddenly increased quite considerably, which we haven't. It was all of the Pillar 2 cases for the whole period cumulatively being added. So just to give you a flavour of why it's so important that we get the most up-to-date data.
Thank you, Helen. Jeanette, any questions or comments?
Yeah, thank you. Helen, can you just explain, because this is a public meeting, that this plan is not a fixed plan and how much it could sort of change and how fluid it is, so people understand what this plan is for and why it's quite important?
Yes, thank you, Councillor Smith. So we, as I said, we published our Portsmouth outbreak plan on the website last Tuesday, and we also put a more resident-friendly explanation of what it is on the website as well. But it's really important that you point out that this isn't a static plan, because obviously the guidance is changing all the time and the situation is changing. So although we've put it up on the website, it will be continuously refreshed and looked at as any policy changes or itself guidance changes, or we adapt how we're managing our outbreaks. So the plan itself describes the key, I suppose, organisations involved, their roles, and then we go through each of the 7 areas that we've been asked to include, and we have the detail of actually how we will manage outbreaks in those settings. So whether it's schools, care homes, or homeless hotels, etc. Or areas of interest at the moment, you'll be aware from the international evidence from food packaging companies being specifically, or food preparation, large food preparation. So we know that we've had an outbreak in the north of England around a meat packing business. Now, we don't have any of those large, I think the largest we have is a food preparation organisation, and they have 30 staff. So we don't have the really large ones, but it basically describes, and of course things as they change, we'll have to adapt that and update it as we move forward, because it's fair to say these outbreak plans will be with us for some time now. So to put it into a context, until we have a effective vaccine in place and everybody vaccinated, we will be managing what I would call spikes of infection. And the whole point of having the outbreak plan is to mitigate against that. So what we're trying to do is keep out of, obviously, we're coming out of lockdown. We want people to go back, to ensure that we keep the economics of Portsmouth safe, as well as our residents as we come out of lockdown, the economy going. We need to be able to manage very effectively spikes of infection that might happen around places, businesses, settings. So it's really important that we do keep it up to date, and it's a fluid document.
And sort of final comment for me, I sometimes think that public health are the forgotten service in all this. because ASC are thanked and CARE, and quite rightly, in the National Health Service. But the work Helen and her team have done in public health has just been outstanding, and I'd like to put my thanks to that. And I know it's ongoing, and I know it's not going away, because there might be further spikes, but the response up till now has been fantastic. So thank you very much.
Thank you, Councillor Smith.
Thank you, Jeanette. Again, I obviously thanks to the public health team. Public health is really at the heart of everything we do in the city, whether it's COVID-19 or not. And we've had many discussions, both on this forum and elsewhere, about the fact that public health sort of goes into pretty much every working of the council there is, and pretty much every bit of our community as well. Whether it goes from mental health to substance misuse to fit and healthy lives, through to things like the infection control and everything, and it really is a key to what we're doing. And I think putting everything in the context that we're doing COVID-19 in the widest context possible is really important. I just want to mention a bit more about because the member-led local engagement board is actually not a public meeting, though it does report into the Health and Wellbeing Board. I just thought it'd be useful in a public forum just to say, because obviously it's on the report, but just to say that it's a group with 6 councillors on it, cross parties. So Jeanette is on there from her group, and then we have one from Labour, 2 from the Conservatives, and 2 from the Lib Dems, including myself. But then also we have Linda Colley from the CCG, the Clinical Commissioning Group, so representing the NHS and our local GPs in the area. We have Helen on there as Director of Public Health, but we also have representatives from Health Watch that represent patients in the city. We have representatives from Shaping, which is about the business community, from the Portsmouth Education Partnership, and also the Hive, which represents the voluntary community sector. So, and we are the statutory board that has been set up by government that says each local authority has to have one. That means that we have the responsibility to oversee that outbreak plan, to make sure that it's really connecting in with our community. And the other thing I'd like to say, and again, this is huge thanks to public health, and again, this is the real unsung bit of public health, is the intelligence side, because without intelligence, this council would not be able to do what it can do. And whether that's public health, whether that's adult social care, whether that's transport, any other part of the council, you wouldn't be able to do what you can do without knowing what is going on. And so the work on intelligence, which is ongoing, looking at any further outbreaks of COVID-19, is really, really important, so we can model our response, so we can be ready for when it comes, so we can effectively get together a pattern of things that will give us warnings for any issues in the city. And then that means that the kind of work that's going on, that we've heard about in adult social care, and we've heard about now in public health, that was going on well before the virus hit this city, which made us well prepared for it, means we can do that even more so going into the future. So it is without public health, we wouldn't be in any position to be able to combat this virus in the city at all. So it's really good, and I'm really pleased to accept and note this report. So, ladies and gentlemen, thank you very much for coming today, and to anyone watching at home, apologies to anyone here as well for the glitches we've had. This is our first cabinet member or cabinet decision meeting done online, so this is the very first one, and the only one we've done other than the full council as a council only public meeting so far. So thank you for bearing with us, and hopefully the glitches weren't too getting in the way of what was going on, and people could follow it. But it's the way we're going to be doing for the time being. And thank you everyone for coming today. And I'm off to another online meeting straight after this, which is, I think, pretty much the way it's working these days. But thank you very much.
Thank you, Councillor. I'll now stop the recording.
Thank you. Okay, we stopped.